So my name is Chidom Otogo. I work with the Canadian Alliance, and I'll be moderating this session. I think I would like to invite the presenters to, if you don't mind, coming to the front and take your seats. Oh, I thought you're 4, right? 5, okay. You can just stay where you are because of, but then during the question and answer, you can come here because of the mics. You need the mic to be able to address the questions if they have some. I think before we progress or we continue, I would like to do a quick land acknowledgement. So the conference, the 2024 National Conference on Ending Homelessness is being held on the traditional unceded territory of the Anishinaabe-Algonquin peoples. The peoples of the Anishinaabe-Algonquin Nation have lived on this territory since time immemorial. Their culture and presence have nurtured and continue to nurture this land. We acknowledge and celebrate the many First Nations, the Métis, the Inuit peoples from coast to coast to coast who participate in this conference and lead the work to end homelessness across the total island. Having said that, I think I can invite the first presenter. I would like to actually give the presenters the opportunity to introduce themselves instead of me introducing them one after the other. So please.
Okay. All right. I can be heard. I'm good. You're good? Solid. All righty. Let me just, I think it's that button. Haha. Okay. Hi, everyone. My name is Brenna Sych. I am the Community Engagement Manager for the Homelessness Information Partnership Saskatchewan, which is the partnership of agencies in Saskatchewan to use one singular database, HIFIS. And so I'm here today to kind of talk about what the project is. I'm going to put those there so I can see them. And how the multi-community partnership came to exist, the timeline of the development a little bit, the benefits, the struggles, the solutions we found to those struggles, and also extra things we've done to make life a little bit easier using HIFIS and a singular database. Now, this is going to be a little funky. Okay. Now, we are here today on the unceded territory of the Anishinaabe-Algonquin region, but I also want to acknowledge that the work that I do and the work that the agencies do is on Treaty 6 and Treaty 4 territories, which encompasses the land of the Cree, the Saulteaux, Dakota, Nakota, Lakota, and the homeland of the Métis Nation. And so the work that we're doing is on those treaty territories. Now, a bit about the partnership in itself. In Saskatchewan, I'm not sure if there's 3 major communities and they're DC-funded community entities. And the goal at the time in 2019 was to develop one shared singular HIFIS or homelessness information management system. Now, the goal of this was to reduce transience, to understand transiency within community. It was to better understand the supports needed in a multi-community database and to reduce and prevent homelessness in Saskatchewan. Now, trying to get multiple communities to work together with different data share or with different coordinated access policies, different assessment tools, everything like that, it is a very large process. And of this process, there needed to be a accountable organization or a lead organization on the administration of the HIFIS system, or HIPS in Saskatchewan, because we really like acronyms, so it's really fun. Now, in 2019, when Reaching Home and DC community entities started coming about, it was appointed that Saskatoon Housing Initiatives Partnership, SHIP, another acronym, is going to be the HIFIS lead organization. And that is who the federal government instance of the HIFIS system is nested under. We hold the instance and the license for HIFIS in Saskatchewan and all the data sharing agreements with the agencies. And so it's one cluster for everybody in 37 agencies in Saskatchewan with multiple geographic regions. Now, I wanted to provide a bit of a timeline because HIFIS is a lot. For anyone that doesn't know, the data infrastructure of the system, it can be overwhelming, along with the privacy guidelines and everything along those lines. And so in 2019, SHIP was appointed as the lead agency. And then between 2020 and 2022, the infrastructure, including the governance, the data sharing agreements, system content, everything to build the infrastructure of the system was developed. And then between September of 2022 to December of 2023, we onboarded 29 organizations onto HIFIS across the three main community entities, which is Saskatoon, Regina, and Prince Albert. And then in January of 2024 to present, the Métis Nation Saskatchewan joined the HIFIS partnership and started funding the HIFIS project, meaning I'm now going into rural and remote communities. So we're onboarding those onto HIFIS. And so that's allowing us to greater understand the reach within the community, greater understand how we can work together to get agencies on board. Now, in this time, it has not just been me. HIFIS is a large project that if you have a team in itself that just runs a data system, you need a very solid team as well. So I have a team of, well, now it's 4 staff. It was recently 3 staff, but now it's 4 staff. And so we handle all of the administration of the system, from community engagement to, here we go, 1 lead administrative team. So we handle onboarding of new agencies. We handle communication, education, training, everything under the sun that you can think of regarding HIFIS that isn't data entry, my team does that. And so quality, making sure consents are active in the system, everything along those lines. And so it's very much a third party from coordinated access, very much separate from those types of operations. And we work with every single community entity that uses HIFIS to ensure that the data in the system is accurate, correct, and can work together. Now, 1 lead agency, meaning there's not multiple data sharing agreements in place. There's 1 agreement with the service provider and HIFIS lead agency. This also means we have 1 consent because we operate 1 cluster. So that consent is for the entire system. They either consent to the entire system to be searchable or they do not. And so building that in created a sense of working together. It allowed staff to see if people that they were serving were in other communities. It allowed to see, oh, we can see transiency between communities. Clients do not have to reconsent to the system again to continue, like to another system, sorry. They do 1 consent in the system. It will expire within a year, but they do 1 consent and they can travel within communities. So it gives us a better idea of where folks are and how to serve them. Now, for anyone who uses HIFIS, it isn't perfect, but it's good. It's very good for what it works for. We face some very unique issues based on having multi-community systems on, or multi-cities on 1 system. Now, some of those issues are the geographic region on HIFIS. As we use it, it must be manually updated for service area. I'll show you solutions after this. We didn't keep with these problems. But now, coordinated access on HIFIS for geo-regions, for multi-communities is not necessarily usable based on privacy. Geographic region is searchable in the module. It's kind of after everyone appears in the module. And then different processes and assessments in each community. No one chose the same one. So everyone does things a little bit differently in Saskatchewan. So 1 community will do the SPDAT, 1 community had decided to develop a custom survey, so those different accountabilities are also built into how we operate it. And then reporting Reporting standards differ by community, differ by agency. One CE may have different reporting requirements than the other CE just based on outside of reaching home requirements. And then if they have external funders, that's also another factor. And then agency use of the system. Not everyone works in the same way. We had to identify how they could use the system and in what way. And data accuracy. We have 37 agencies currently using HIFIS and with over 300 users. Lots of things can go wrong when you have that many people using the system and entering in data. So ensuring data accuracy and input, creating standards of what could be entered into the system. So these are all issues that we've both identified and also found solutions to. So and lots of these were both by processes, both by how we operate the system. Now, regarding geographic region, my team developed a customized report that matches a client's most recent service interaction to their listed geographic region. And then we can go in and we can audit. It's not the perfect solution right now, but it is the one that's working. And education, ensuring that staff understand what portions that they have to interact with to make the system work in the way it's intended. And then with the multi-community system and coordinated access, the development of the prioritization report for each community that focuses on the local policies, the local prioritization matrix, and all of those. And we are continuously adapting all the time about how those procedures work, as well as creating procedures specific to data entry. And I'll have a bit more on how that works in each community. Now, the reporting side, if you're going to do anything on HIFIS, get someone who can write reports. It's the development of custom reports that have really enabled us to show agencies the benefits of the system, to show how their data looks directly in the moment of interaction with the system. They enter in case management, it comes out and it shows what they're doing and what they're working with. So it really almost sells HIFIS in a way, which has really allowed us to do that. And creating a standard module-based reporting. So based on what the agencies do, if they're housing support, if they're a service provider, we've created and are continuously in the process of creating a standard set of reports for what they do. And that way they can tell me if there's anything outside of that they need, we can adapt for them. And then development of online training course that staff at agencies must take before being allowed access to the system. And that's role-based, so what they do, role-based, not results reporting, but role-based. So develop of that online training course, they have to go through that course before they're even allowed access to the system, meaning that we have control on making sure that they have the right level of education to interact with the system in the best way. And then data accuracy, a standardized data audit and system checks to ensure information is correct in the system. And those look like ensuring case management is closed if they're no longer serving them, ensuring that everything to make truly it's sending information and saying, is this correct? If it's not, here's how to fix it. And working with agencies to understand why it's incorrect and how to fix it. Now, coordinated access in itself is something that operates in all the major three communities in Saskatchewan. And for coordinated access specifically, there were things that we identified we needed. And this is a referred caseload. So in HIFIS, we actually use the waiting list module for coordinated access to assign and refer clients to partnered agencies. This allows other agencies to see, oh, you're on X's caseload. In the waiting list module, we'll refer them to you. It also allows agencies to see a list of their individuals that they may not have developed a case management file with yet, anything along those lines. And so then building off of that, from the waiting list module, we created a caseload report that will show SPDAT score, that will show housing placement, current housing status, activity status, expiration of consent, everything that they may need to know in a one snapshot to see how they can work best with their current caseload. And then coordinated access procedures. This was done very much hand in hand with Coordinated Access Regina, and they, using their policies, and we created guidelines for agencies on how to interact with the system. So upon receiving a referral or notification of a referral from coordinated access, you open a housing placement and you get in contact, and with that getting in contact and committing to working with them, you open a case management file. And so setting those requirements allowed us to then, when it came time for reporting, check those requirements, almost a checklist of how they work with people to ensure that the individuals are being worked with in the best way for how they need to function. Now, system development, there is a very unique to us, governance structure set in place. For Saskatchewan, it is a very large concern regarding data sovereignty and the release of data and how it gets released and who has ownership over that release. And so we focused on the community implementation of coordinated access and strengthen the alignment to the OCAP principles through the correct approval processes to release data. And I'll go over my governance structure on the next slide there. And I mentioned the data audit. These are standardized data audits that we work with agencies to ensure that they know how to work with people. Now, a bit on our governance structure. It can get complicated, but it's fine. Now, I run the HIFIS lead team, which is my team who administrates HIFIS in Saskatchewan. I work hand in hand with the HIFIS advisory group, and these are comprised of participating agencies, so those who have signed the agreement in Saskatchewan to be part of HIPSC. And so they offer guidance on implementation, coordination, consent, how can the system adopt and evolve. And then I report to the HIPSC leadership group, which is made up of currently CEs and community advisory board representatives from each community. However, that group is not limited. It is intended to be representative of the community that we serve. And so that group can release cross-community aggregated data, so multi-community, that can never be tied back to an agency. I want to clarify also that agencies' data belongs to them. It does not belong to HIFIS. It does not belong to SHIP, the organization that I work for. It is not our data. It's the ownership retains with the agency doing the work. And then I work with each coordinated access governance group. In some communities, that is the CAB, but in other communities that have a larger and more expansive coordinated access, those are the ones that can release community level aggregated data. So they can release stats on the community itself. And those groups are representative and representatives from the group and the community that they're serving. And so within this, we hand back ownership of data to the community and to who they're working with. Now, I was 4 minutes faster than I timed myself. So here we go. Now, oh, hey, okay, cool. So how do you get started on a multi-community system? There are understanding the benefits. Having one database for one set of data to work together to allow people to see, oh, you're on their case, they have a caseload open with you. Let me get you in contact with them so that they can work with you. They don't see what you're doing, but we can make sure that you get in contact with who you're supposed to be in contact with. Engaging the community in the development. Get them excited to work together to really help those that we're trying to help. And then clear administration and management, setting boundaries and guidance on how the system works, who operates it, who does what, and whose responsibility is it to do those things. My team manages administration, so anything that's like from shelter beds needing to be created to staff being trained and onboarded, my team handles that. And then guidance and processes for all levels of access. Turnover is high. So training and making sure that guidelines are in place and that there's documentation so that staff can follow how to do things is a very large factor. We also operate a help desk, and so making sure we're always available to help those that we need. And it goes, if there's a system breach or system interruption, that goes directly to our 24/7 IT support. So we have those supports set in place. Yeah, so that was HIFIS in Saskatchewan, homelessness information Partnership Saskatchewan. Thanks. If you want to get in contact with me, my details are there.
Thank you. Thank you. Next, our presenter is Jackie from Homeward Trust.
Hi, good afternoon. Hang on. Let me get my kit on, and I'll get started. Okay. How's the sound? I don't want to do this. It hurts my back. Hang on, sorry. I guess that's what it is. Okay. Can everyone hear me okay? Perfect. Okay, so good afternoon. Thank you for being here. My presentation today is on advancing homeless solutions through system accountability. So to give a bit of context to this, this presentation is related to the work in Edmonton to update the community plan to prevent and end homelessness. And so I'll just spoil it for you. There's not a whole lot of data being presented, but in terms of sort of how we structure the system accountability framework and our approach to it, that's what we'll be chatting about. And looking forward to a discussion and questions, at the end of the session. So I want to acknowledge that I'm coming to you from Treaty 6 territory. I live, work, and play, in the city of Edmonton right now, and this is our sort of our standard land acknowledgement. But I will acknowledge, I want to acknowledge the lands of the people that Homeward Trust works in, and that's the lands of the Cree, the Blackfoot, the Dene, the Iroquois, the Anishinaabe, the Nakota Sioux, Inuit, and Métis. And the Inuit are there, and and we have the good fortune, to live in the lands that they've stewarded and shepherded since time immemorial. And of course, I'm so pleased to be a visitor here in the unceded territories of the Anishinaabe. Okay, so who am I? No one online can see me, right? So I'm Jackie Liu. I'm the Chief Impact Officer at Homeward Trust Edmonton. And so just a little bit of context to Homeward Trust. I won't read this slide, but Homeward Trust is the community is the provincial, or sorry, the federal community entity and the provincial community-based organization. So we're the system planning organization that stewards the three levels of funding, and we're the homeless system planner and one of the principal funders for the homeless serving sector in the city of Edmonton. So we've been in the game for a while. I myself have been at Homeward Trust not that long. I moved to Edmonton I moved to Edmonton to commemorate the start of the pandemic, but Homeward Trust has been it has been serving Edmonton since 2009, and so at this point, just want to highlight that the system Edmonton has housed almost 20,000 individuals since 2009, and so it's an incredible amount of work done by an incredible number of agencies. As of right now, Homeward Trust funds almost 100 different programs across 27 organizations in the city of Edmonton, and so it's a phenomenal amount of work done by many, many phenomenal people, and so I want to acknowledge that. And I guess that leads into the premise of the presentation, which is like, who are we really, right? And so I think those of us in the homeless serving sector typically, I think, feel like heroes, perhaps, right? And so you're impacting, you're impacting very significantly the journeys and trajectories of people's lives, and so rightfully, you should feel very great about what you do. However, I've used this slide in different presentations and probably always will. I think it's very important for us to understand that, or sorry, not to understand. It's important for us to visualize the homeless serving system in amongst the massive social support network that actually exists. So, in the middle of the slide is our housing homeless serving system, right? We are a small part in the experience of the individuals that we serve. And, I think it's really important to contextualize that we are not the only ones. And so, there's lots of great presentations, a lot of great experience and perspectives that are shared today from so many practitioners. We are a part of the system. In a less flattering way, we're almost a rounding error. in the grand scheme of systems, that exist, to support people who are vulnerable, people who are experiencing homelessness, out of the approximately $7.5 billion that make up Edmonton's social safety net, and that's including all of healthcare, education, justice and corrections, our budget of $70 million is a speck, and I suspect, that those of you in the room, it's a similar type math, right? And sorry, and I forgot to do this. Just people in the room, is there, I don't know, just a quick show of hands. Are there other, I guess, community entities, CBOs in the room? There's a few frontline practitioners. Okay, are there any government officials? Okay, are you from Alberta? Do I have to be careful? Or, no? Okay. Okay. Kidding. Jokes. Sorry, and just to get some context of what our conversations are. And so, with these numbers in mind, I think it's, a different way to contextualize ourselves and superheroes is actually who we are. But we're probably more like these guys. And I don't know if there's some copyright infringement in this presentation, to be fair, right? And so, instead of superheroes, I think it's actually helpful to think of ourselves as possibly hobbits. Are we familiar with these folks? I'm not going to go into the whole, it'll take a while if I have to explain it, right? But those of us, with stout hearts and great intentions and courage can accomplish great things, right? And so that's an important context for what we do. Also important is it's really helpful when you have a guy with a sword, a bow, and an axe, and a wizard to help you out. And so, you can gauge for yourself which system is what, right? But, the path of success is really through, allyship, fellowship, I suppose you could say, and so coordinating the homeless serving system in amongst all the other systems is what we're talking about today. And so, although there's many parts of the accountability framework, I want to focus on three that are particularly pertinent to our current conversation and in the city of Edmonton. Does my sound okay? I feel nervous. I don't know am I a little quiet? The hyphus guru told me I was quiet, so I gotta speak up. Okay. Thank you. Okay, sorry, I'll lean in just a little bit here. So I do want to focus on three of the key systems, and that's that's housing, recovery, and health. So the conversation will go through each of these realities, and what I hope you'll gain from this is not just the superficial check marks that we sometimes give systems, but conversation of how we might consider these systems in the context of community planning and what type of data and inputs we may actually use to gain a measure of accountability through these systems. So diving right into it. I'm just going to go out there and say that healthcare is not a checklist item. And I think in many cases, I view it as it feels a checklist item. Does that resonate with people? Right? There'll be things like, hey, is there mental health supports on this outreach team? I'm like, that's great. I wasn't aware that mental health was a spray application. And being glib, right? But it is not a one-time interaction. And so healthcare in many instances is transactional, for the people that we serve. And unfortunately, it's polarizing. Right, headlines like the one above, are very, very common in context of healthcare, and I put that up there not to, I'm not drawing attention to it because it's a great fact. It's not a good one at all, but it's actually helpful, in my opinion, to shift the conversation of healthcare. Do you have access to healthcare that's beyond basic wound care, infectious disease testing, and that sort of transactional care, and do you have something more tangible? And so, have folks in the room seen something like this? In a doctor's office? Yeah, so some of you have no idea what I'm talking about, so good for you. But in a lot of clinicians' offices, we see some variation of this sign, right? There's further signs that say like this, one point and one problem. It's enough of a problem, I guess I would say, that the CMPA actually warns physicians that this is not a good thing to do. And so I'm obviously not here to trash physicians, right? But what I want to draw a contrast to is the provision of healthcare should not be that transactional. Did your case management team, did your housing support team connect someone to, a walk-in clinic? Did you actually tangibly connect someone to healthcare, and what does that actually mean? And so, I'll reveal a bit of my personal bias in that I want to talk about primary care, and I want to make that connection, I guess, statistically, to adverse childhood experiences. And are folks familiar with ACEs, or adverse childhood experiences? I guess, yeah, most nods. Okay, so I won't go in depth into this, right? But I do want to highlight, I guess, a very important correlation. So average childhood experiences, and this isn't my slide, I stole it, there's a reference at the bottom. There's a very strong correlation, of course, you would suspect, of folks experiencing, with adverse childhood experiences, experiencing future experiences of homelessness. And that correlation looks like this. So of individuals experiencing homelessness, close to 90% have had at least one adverse childhood experience, and greater than half had more than 4. And that contrasts obviously quite starkly with the general population, where those numbers are under 40 and 3 to 5%. So you're with me? So that's no surprise, right? Obviously, that people, who are experiencing homelessness had a traumatic experience. The correlation that I think is quite direct is the information on chronic diseases and the incidence of adverse childhood experiences. And so, looking at the original genesis of ACE scores was obesity in 1985 in, I think, San Diego or San Francisco. And so, looking at the correlation of chronic diseases and ACEs. There's a strong correlation. And, those of us who are, I guess everyone who's in the homeless serving system working with data, we don't have access to, or many of us don't have access to health data. I would go so far to say is we don't want access to health data, but it's also very important to have. And so while much of our health data is currently self-reported, if it's the SPDAT or whatever assessments that you may use yourselves, it's all self-reported. But we know, statistically speaking, that those same people who have 4 or more ACEs are almost twice as likely to have chronic diseases like diabetes. They're 2 to 3 times more likely to have conditions relating to your heart or cancer. A 3 to 6 times likelihood of alcohol use or sexually transmitted disease, and of no surprise to anyone, a greater than 7 times chance of having a significant addiction. And so the correlation is so very, very large that when we look at the provision of healthcare and the availability of it, it's not so much did you see a doctor or do you have access to a nurse practitioner. It's are you on do you have access to regular primary care, and if you don't, how do you design your programs to either fill that gap or facilitate that access, right? And so just some further statistics from our 2022 PIT count, just showing that correlation to health conditions. And a small plug, I guess. So the Canadian Alliance, or the Association of Community Health Centers, that's a good model of care that really, if possible, people can be connected to, and then just plugs for places that I've personally worked, right? So, there's Radius in Edmonton and the Alex in Calgary, examples of, great examples of primary health care and how a healthcare team should be structured. And so on the screen, I won't read it to you, but when we're looking at how to track the accountability of healthcare, it's not so much, I think, just the checkbox of did you get it, but actually, what kind of healthcare did you get? What was the incidence? Is there routine follow-up? Does that practitioner identify as that person's family doctor or nurse practitioner? Like, those are the questions that are much more telling than just did you receive healthcare? So that's the theme of this whole thing. Cool? All right. So then moving to the second reality, so the recovery reality. So some of you may know, Alberta's recently restructured Addictions Mental Health into Recovery Alberta. There's a whole lot of conversation that I won't get into about maybe the delivery of the healthcare and some of the priorities. It is important to recognize, as I think everyone and no one would disagree, that access to addictions and mental health services, if they're called recovery services, are absolutely vital, and that everything is on the spectrum of those services, and they're absolutely important and critical to the success of ending homelessness. Great evidence in media and otherwise showing that the approach actually has some success, right? So I think, a general statement that's probably true is, a lot of mainstream recovery services work very, very well. They may or may not work very, very well for our community. That is what our services are meant to reach, right? And so looking at, the recovery reality of Edmonton, again, our 2022 PIT count shows, I think maybe a higher than expected dependency on substances. We'll have our 24 data hopefully, soon, and we'll get an update on this. But it's a very, very big deal for us. The incidence of addictions and mental health in our community. And so, again, leaning on self-reported data from SPDAT or assessment tools, we know this already. How do we track it? And that's what we got to get into. And again, another slide that, you're not meant to read, but, for us to actually properly end homelessness, we have to look at tracking things that are beyond just, did you receive supplies? Did you receive a referral? We want to look at things like referrals made, the acceptance rates of referrals. We want to look at completion of programming, if those are metrics that are kept. And further, there's a little screenshot in the corner. The use of standardized and validated tools is an approach that I don't know if folks have adopted in the homeless serving system. And maybe I should preface this with like a reformed health professional, right? So like my whole life has been built off of validated scales and things that are frankly very institutional and non-trauma informed for our community, right? The greatest of assessment tools typically come with a high degree of invasiveness, right? And so for us to find a tool, and so in the corner is a tool called the DUDIT, which seems promising. We haven't implemented it, but just as an example of, is there a validated measure of success off of someone's dependency of substances where a non-health professional can actually do that so that, it actually doesn't matter what you're referred to or what services you have access to. It's just, what is your dependence on the substance? And is it less than it was before? And if so, then our program has shown success. So taking the metrics, into tracking a different type of metric to show success and not always just service connection. With me? Okay, and then the last thing to track for us is the housing reality. And so, many people more intelligent, more informed than me will speak about affordable housing and the access of it. We know there's not a lot. I don't want to talk a huge amount about it. I think what is very important for us is to look at affordable housing in the context of how well it serves the population that we serve. And so, I absolutely don't want to paint a situation where we're in competition with other service streams or the general population. Looking at average rents in Edmonton, we're winning, I guess, compared to some. We're higher than you, right? And that's not necessarily a good thing, of course, with income support levels, insufficient to meet those needs. And so what's really important out of this is how quickly, how easily, how readily are individuals that we're supporting through caseload, on our by name list, how readily and easily are they able to access affordable housing and or rental supplements. And that's a critical thing to track. I want to highlight something cool that I learned at, recently, and that's the HICO, or the Homelessness Income Cutoff. And so I don't know if I don't see Ron Nebo, and I think he's somewhere in the room, or he's somewhere in the conference. But it was a really great approach for me, looking at some research done in Calgary about the Homelessness Income Cutoff. And I'm not gonna repeat Ron's work, but the approach that I thought was just very, very exceptional is, we look at a LICO, we look at people's income. The HICO, I think for me, I've contextualized it as like, what are the lengths that people will go to maintain their housing? And so I think if we think to our own experiences of housing, back when presumably you moved out for the first time and you maybe had a roommate, maybe you chose something that wasn't quite what you wanted, right? Maybe mom and dad picked up the Costco bill for you and or you access the social services. Like, those are things that people do to survive. And, in a very humanistic way, a lot of the services that we fund, support, provide, they are doing that. How are all of the teams and supports that we're working with, how do they actually help people, frankly, cut those corners so that they're able to maintain their housing? And so that's what we're looking at. Those are those numbers. And so the accessibility of affordable housing, is really critical. I know that's a little bit tough to read. Maybe I'll just skip that over, right? But looking at, again, just a summary of the HICO research, because we can't, I think, as a social service sector, advocate for moving to unsuitable or overcrowded locations, we can do what we can to facilitate people's access to charity. Like, what we actually need to track and prioritize is how quickly and how readily are people able to access rental supports. And so again, moving to the last slide, what we should be looking to track, right, as a performance metric, rent to income ratios, time spent on waiting lists, making sure that people have actually applied for affordable housing at the right time. There's a lot of standards of practice that I don't know if this is true elsewhere, in the country. Certainly in the city of Edmonton, we've had a lot of turnover in the social service sector, and so those things that are routine and second nature, like applying for affordable housing. We need to make sure that it's happening, and one of those ways to do it is, possibly a bit of a force function through reporting. So, how are we looking at people and their experiences in accessing affordable housing? So, in summation, really emphasizing that, the work of the homeless sector, is mighty. It's absolutely critical. Much respect for the work that my colleagues, your colleagues do, but we are one part of a whole. And so, for us to actually end homelessness, it's not just how hard we work, right, or how great our intentions are. It's how we can actually coordinate the activities of the whole to bring that accountability to other systems, make those accountabilities real, make those accountabilities something that they care about, not just us. And only in doing that will we actually once again make very tangible progress towards functional zero. And so that's what we are, right? We're part of a team. Everyone needs to play their role. And so that's what we are, right? Clear purpose, measure what matters, and then be very, very specific with how we track accountability and what we ask of other sectors. So thanks for your time. And there's my contact info.
Thank you, Jackie. Our final presenters from Mission Services Hamilton, I'll give them the opportunity to introduce themselves. Yeah, you can all come up together.
Hey, is this you? Are you safe? This is you, right?
This is us, thank you.
Okay.
I thought we'd be sitting. All right. Yeah, thank you for having us. We're here to talk about the Safe at Home Hamilton's operations table. To give you some background, Safe at Home Hamilton is a homelessness prevention program for women and gender diverse individuals with or without children who are experiencing intimate partner violence. The program provides the option for participants to stay safely in their communities, either by providing support in their home or supporting participants in moving to another home. Safe at Home Hamilton is a multi-sector, multi-agency, and multi-level program that relies on service provision and referrals from multiple agencies within Hamilton. Who are we? My name's Andrea Krock, and I'm the program manager for Safe at Home Hamilton, and I work at Mission Services. I'm joined by, on the far side, Cashlyn Fullerton. She's our logistics manager at Mission Services. And last but not least, we have Allison Branston, who is our research coordinator. She works at MAP, the Center for Urban Health Solutions. Safe at Home Hamilton has an academic community agency partnership. Safe at Home is delivered by Mission Services of Hamilton. The MAP Center for Urban Health Solutions supports the program with research evaluation, including implementation evaluation. So we're very lucky. Today we're sharing this model so you can consider if it is one that you want to use within your community. If there are data sharing or coordination challenges that might be improved by the creation of an operations table, we are hoping to share the tools and forms needed should you consider this model. Here are some questions to consider throughout the presentation. What service provision challenges in your local context could be overcome by using this model? What agencies would participate? What would the goals of the table be? And what barriers to implementation might it face? I'm going to hand the microphone over to Cashlyn to explain why we created the operations table and the role that data plays in it.
So I want to talk a little bit about what led us to the operations table. So the operations table was created as a response to a couple questions that we had. Firstly, how can we establish new systems of cross-sector services delivering in a new program? So in order to effectively support clients, we know a holistic approach is essential, and we need to provide wraparound services. There's a need to establish new systems of cross-sector service delivery, as this is a new program and services are learning how to do things differently. Additionally, how can we communicate most effectively to coordinate the delivery of these multi-sector services? So effective communication requires frequent conversations with all who are involved in service provision. Ideally, these conversations happen together. And where will action be taken on implementation evaluation findings? So the research team is working to support implementation of the program by identifying threats to program success. But action is needed to avoid program failures. So we developed the operations table by recruiting frontline workers from agencies that provide services as part of our Safe at Home model. When the program launched, the operations table was created as a way to gather insight and guidance from staff and agencies involved in direct services. And this includes referral partners of the Safe at Home program. And as you can see, these are our pillars of our programs. So our hope is to engage service providers from all of our pillars. The operations table exists to review program functions, case management issues, reviewing risk assessments, referrals, and other interagency processes. Members provide feedback on the programs from their perspectives as referral partners and/or service providers, providing guidance and operations and processes as frontline or managerial staff in a sector that overlaps with the Safe at Home mandates. Improving coordination of the program's wraparound services. So having virtual meetings has allowed multi-sector staff to discuss case management concerns, needs, and holds member agencies who have committed to providing specific services to our program accountable. This also provides an opportunity to take action on implementation evaluation findings. So the research staff share evaluation findings with the operations table to gather feedback and problem solve any course corrections that the program may need to be successful. So as you can see, there's a need for a system change. So Safe at Home is guided by a steering committee of over 15 agencies who have led the co-design process of Safe at Home Hamilton since 2020. The steering committee exists to provide guidance and feedback from senior management at partnered agencies. These individuals have the ability to make decisions and commitments on behalf of their agencies. The steering committee reviews Safe at Home policies and serves as a place where issues that cannot be resolved at the operations table or the frontline area so that we can have these larger conversations at a higher level. Whereas the operations table functions at a practice level where day-to-day operations can be discussed. Program issues can be discussed and resolved by the insight and participation of the frontline workers. Evaluation data is brought to the operations table by the research team for review, discussion, and troubleshooting. And I will pass it on to Allison, who will talk about a little bit more of the evaluation and research based.
Hi, everyone. I'm going to talk a bit about the role of data in the operations table. So we use it in a few ways, and one way we use it is to support case management activities and the conversations we have, since we have folks involved in the care of clients all present together. And it's especially important that we keep this confidential because we're working with folks experiencing intimate partner violence. And Cashlyn's going to talk about some tools and conversations that is helpful to have as you're developing your operations table, if that's the case for you as well. So this might be things like risk assessment scores, housing goals. So we might check in on the status of a client, or if a referral's been made and no progress is happening and that service provider is there, we can ask questions, and that's part of the way we hold our members accountable. Another way we use data is sharing program level data. So this allows the operations table to monitor program function. So this is things like how many referrals are being made into the program, common reasons people are leaving the program, how many referrals are being made out, and how timely are they being picked up. So this allows the table to assess the delivery of the program. This is aggregate client data, so it doesn't contain identifying information, so confidentiality in these discussions is less of an issue. But the collection of the data is obviously quite sensitive, in particular client feedback. So this is best done if you have the resources, a third party, or in an anonymous way, that if you could swing it, and we can chat more about that after if folks are interested. Because in our case, we have the research team, so we're able to collect information and provide a space for those conversations to happen. Another way is where we take the implementation evaluation data for review. We take it to the operations table members to say, does this resonate? Is this making sense? What can we do about it? What's missing here? So we want to be making course corrections as we test out this model. We're looking to see how closely we're implementing it based on the design and what changes need to happen to make it even better. So by the time we're done our sort of initial implementation, we know what has had to happen. We've rolled out the changes, and we hopefully have a model that's packaged and ready to distribute to everybody else. So the table is where that action is taken on that data often. We say, so like, for example, if we find that folks are being referred into the program and a lot of them don't meet our eligibility criteria, we would take that finding back to the table and review the criteria, discuss it, and get feedback of like, should we do more learning sessions? Can we develop some materials to share? How can we make this, how can we resolve this as a team? Another way that's not on there is we really see this as an opportunity for building data management capacity within social service organizations. So we can learn through these conversations how agencies collect, analyze, and use data. And we can also discuss what additional data are needed for these activities that maybe folks aren't collecting or sharing, what conversations we need to have. And we can have this be a two-way street where we can talk about best ways to collect it, or can the research team support in any kind of way. So we're really looking to improve the capacity of all involved, not just in their role at Safe at Home, but within the work they do in their organizations as well. And so as you can imagine, communication is a huge part of that. So one of the tools the main tool we use for communication is our dashboard. So this is the evaluation team that myself and my wonderful team create the dashboard and update it every 2 months. And so this is implementation evaluation indicators. So this is, it's available. We have a website and we have a members only page on our website. So our operations table and steering committee members can access it whenever they like. It's not publicly accessible until now. So please enjoy. And we can use this to have We want to flag areas that we're doing well in, for sure, but also the areas where more attention is needed to prevent these, what we call implementation evaluation failures, or just barriers to implementing the program to the best of our ability. So we provide a program snapshot as well to provide a little context for folks. I just put a snippet here, but we also have like how many folks are active in the program at this time, how many housing allowances have we accessed, how many safety enhancements have we distributed, things like that. So folks also have a chance to feel like they're kept up to date, and hopefully that increases buy-in, because we have a lot of agencies who participate in Safe at Home, so we have to make sure everybody's feeling like they're part of the process. So the data that populates this comes from client data collected by program staff and analyzed by research staff, as well as data collected by the research team, as I mentioned. So these are used to answer our evaluation questions, which you can see here. For example, like, have we received referrals from all referral partners in the last 6 months? And these are things that can flag for us the areas that need more attention. So we take this to the operations table as well, so we can troubleshoot, and as Kashlyn alluded to with the diagram, that's where we can solve problems together for these day-to-day issues. And if we feel like we can't quite figure things out, or we need like a few more decision makers to weigh in, we'll send it to the steering committee, who meet quarterly, to have more conversations about it. And I'm going to hand it back off.
So I'd like to talk about some of the data sharing considerations if you're looking at building your own operations table or something similar. And these are some of the things that you probably already have, but just things that you would want to confirm that your agency would have to support the operations table. So you'd want to ensure that your agency has data and confidentiality policies and protocols. So research policies and protocols are really essential if you are working with researchers or third-party agencies to support your programs. Did I go to, nope, we're good. Sorry. Confidentiality policies, privacy breach policies, response procedures and incident reports, policy on data collection and storage, yeah, oh, okay. I don't know why that, anyways. You'd also want to ensure that you are aware of what legislation your agency follows and those of your partners. So as you can see, these are the ones that Safe at Home adheres to. So you would want to ensure that you're aware of what your legislations you need to follow, and what legislations the partners that you are coordinating services with also follow. And these are some of the things that you probably may or may not have, but would be beneficial to support the operations table within your agency. So you'd want to ensure that you have a term of reference to clarify everyone's roles and goals at the table. So this should be provided to all of the members and reviewed to ensure accuracy and consistency, to ensure that everybody is on the same page, has the same understanding. The terms of reference should include the program overview, the committee core tenets, the committee mandates, membership expectations, the purpose of meeting, and what the time commitment is, which is really helpful. Additionally, you'd want to ensure that you have a release of information signed by the participants for the operations table. So this requires having a conversation with the participants about who's involved, if there's any safety concerns at all in regards to engaging with different types of agencies, and ensuring that the participant is okay with us having these larger conversations. We do provide the participant with a brochure of our program, who's involved, what it looks like, eligibility criteria, so that they really have a good understanding of what our program is, what's involved, so they have the opportunity to review and reflect and really sit with the decision whether they want to engage in our program or not. We do acknowledge that signing a release of information that includes various agencies can create a barrier to accessing services. Some folks may not want to engage with certain agencies. However, we do also recognize that many of the individuals that we support are already engaged with these services. And if there is one particular agency that they don't want us to engage in, we can have a conversation about what that looks like and if we can still support individuals with working with the operations table and the steering committee. So these are kind of what our forms look like. And as you can see, we do highlight all of the services in our release of information that we do engage in, so they have a good understanding of who's involved and who's going to be having some kind of access to their information. And then we do have the terms of reference as well that we will review, get feedback, and have larger discussions with those involved. I will pass it on to Andrea about lessons learned. Thank you.
Yeah, so we have learned lessons. Our program is relatively new, and our operations table, thank you. Our operations table is approximately 5 months old. From the process of implementation, evaluation, data collection, and program facilitation, we've learned the lessons listed above that we would like to share with you. Make sure to utilize everyone's area of expertise. You can do this by writing questions and discussion guides in advance and making sure to send out agendas ahead of meetings. Ensure all relevant sectors are included. This will better serve the mandate of wraparound services, as this means providing care for a variety of issues in participants' life. This will also make these meetings most productive for knowledge sharing and determining actionable next steps to move things along for our participants. Buy-in and engagement. We want individuals to participate. We know staff are busy, so prioritizing a table like this, it's not at the top of their list when there's so much to do. We include presentations that are relevant to members' work to ensure we're giving something back to them. We found that having a staff to coordinate the table, doing things such as scheduling, agendas, facilitation, and minutes is extremely beneficial. Making sure the program is the priority and adapting meetings to match. Due to the wraparound supports, some content is not relevant to all agencies present. Something we're considering is alternating case management focused meetings with program level meetings. And ensure the goals of the table and roles of the members are made clear. As Cashlyn mentioned, we created a terms of reference for the table to achieve this. One more.
Before I just go into the last piece, I did also want to mention that we do have little handouts at the front. It's fine. Oh. We have handouts, if you'd like, up front that goes over our program, our pillars of our program, who is eligible to participate in our program. It has our website. Additionally, it does have the framework for gender transformative approach, which is the basis of our program. And I'm happy to have a further discussion if you'd like. And we would love to hear if you have an operations table or anything similar so we can share and learn from each other. If you'd like any of the forms that we have or any other further information, please contact me. My information is up there, or there is a comment section in our website, and that all gets directed to me, so I'd be happy to have any further discussions if you'd like. Thank you for joining us today, and I appreciate the time because it's kind of late, so I hope everyone has enjoyed. Thank you.
Thank you. I would like to invite Brenna and Jackie, if you don't mind, back up here for the Q&A session. So if you have a question, if you just line behind the mic, That would be great. Yeah, Jackie, you can just stand.
I don't fight, it's okay.
It was very heavy.
Yeah. So if you can line behind her, I'll.
My question's for Jackie, so you better sit down. Okay, so I'm not in direct service provision, and I'm definitely not in healthcare. So this is a very uninformed question, and I apologize if everyone in the room knows the answer. That's not me. So you were talking about how important it was to get people connected to healthcare, but not just a transactional approach, like more having a ongoing, consistent doctor. I don't know how widespread the problem is, but at least where I live, there's something like 15,000 people in my city without a family doctor. And so what is done in a case where you're trying to connect someone with regular, consistent health care in an area where like a lot of people don't have family doctors who are housed? Like what is done?
Is this on? So 3 careers ago, I worked with the primary care network in Alberta, and I think that this was like the solution to that problem was like the reason why there's primary care networks. And so there's a few things. I think the acquisition of a family doctor is definitely not in the control of the homeless serving sector. Like that is not something we could do. I highlighted the community health centers during my presentation because those centers and I meant to say, like, those of you from Ontario are probably well familiar with community health centers. You have, like, I don't know, like 200 and something of them here, and we have 3 in Alberta. And so the proliferation and spread of that model of care would be a very great thing for us to be aware of, and just really the approach of like team-based care is like that is a big thing for us as a sector. And I know there's advocates elsewhere in this space, but just the awareness of what that is really important. In terms of what we're doing, you're absolutely right. Like there's a family doctor shortage everywhere, and in Alberta, the problems are possibly, well, I mean, they're not being resolved anytime soon. And so I think for the people in the room, it's perhaps not what we can do to access family doctors, but what programs can you create? What awareness needs to happen in your program design? So, in Edmonton, for instance, we have what we call a clinical access team. And so it's a team that augments the housing support teams or the housing first teams that we have. And those that team is specifically designed so that they can provide that ongoing care and the connections to bridge that case management gap where even if you don't have a family doctor or you don't have a family doctor in the way that you should, at least that team can provide some of that ongoing care. And so I guess the answer to that is accessing existing services where they're capable of, being aware of the quality of service and what you're really facilitating access to, and then where those things are not possible, being really creative in your program design to look at what are those services providing and can you provide them in a slightly different way. That was a good question, actually. Oh.
Thank you. Yes.
Just bear with me. I'm short. Mike's high. I have a couple of questions for Brenna, but they're related.
Okay.
Because I'm in a place where we're looking at doing HIFAs province-wide. Mm-hmm. Not going to mention any province names. How are you looking at homelessness serving sector adjacent organizations? Because we know that there are several that do see people who may be hidden. And the second part is, are you including the type of services and supports and housing that the people from Hamilton have? Because right now, services and housing for women and gender diverse people experiencing violence are in a completely separate, siloed area.
Mm-hmm. Okay. So part of the access to HIFAs is through those coordinated access, designated access points. So in each community, there are coordinated access teams, and they go into corrections. I have teams that they'll go into the hospital and they'll do intakes in the hospital for individuals who are homeless. Now, directly them using the system, we're not there yet. HIFIS was implemented in Saskatchewan 2 years ago. And so we are still building those partnerships out significantly. It's something that I've seen done elsewhere where socials systems work within there, and I think that's somewhere that we want to grow. It draws into data privacy and access, and so that's something that is a conversation that is starting to grow. In what I'm doing, our main focus the last few years has been designated communities, funded agencies, reaching home funded agencies. And so we definitely try to access those spaces with coordinated access and the shelters and get into those spaces where we can better serve and reach people who are experiencing hidden homelessness. It's not perfect right now, but it's something that we are working towards and educate what is HIFIS and what is coordinated access so that those services also understand what's in place. And then your second question, I do have a DV shelter on the system. It is still operating within the same cluster. However, they do use declined anonymous for all of their individuals so that their information isn't even searchable, so that they can still access the system and they can still use the same system as the rest of their agency, but they're declined anonymous individuals if that's what is identified at the point of intake. So if they come in and there is a risk of violence, there is, or there's a risk of, if their information is shared, there's a problem, then they'll be declined anonymous in the system, and so their information won't be shared. And so that's something that is at work in some of the shelters that use the system.
Thank you.
Thank you.
Yes.
Okay.
Hello, my name is Elijah from Winnipeg. I want to piggyback on what the one who just talked said. So for Winnipeg, we've considered making HIFIS province-wide. And I want to know, you mentioned 37 agencies have been onboarded onto HIFIS so far. That's every housing and homeless serving sector agency in Saskatchewan, or that is not
It's all the reaching
everyone?
home agencies.
Sorry?
Reaching home funded.
Okay.
And a couple of shelters.
Okay, good. Has there been any pushback from any agency so far? And if there has been any pushback, how have you dealt with that?
So I'll explain a little bit of how coordinated access and HIFIS got implemented in Saskatchewan. So in Regina, the Community Advisory Board actually mandated that IH and DC funded agencies had to join HIFIS. As you know, like Reaching Home doesn't mandate that IH joins HIFIS, but that was a decision made by the CAB in Regina. And then, so that was part of that implementation. And so from that point, it was about 2 years of work to get it up and running. And so coordinated access was actually launching at the same time in Regina. And then in Saskatoon, we are working very closely with Indigenous agencies specifically. The same mandate hasn't come into play in Saskatoon, with Indigenous agencies mandated to join by the CAB, not by Reaching Home, but by the CAB. And so we're working, and lots of it is showing the benefits. And now that the system is growing further and further, now that I have agencies, Saskatoon, Regina, Prince Albert, and Yorkton. I just onboarded another agency there. They are seeing really the benefits of the system, and agencies are starting to realize if they're not participating, especially with some of the frontline, being able to work with admissions and seek capacity at shelters, they're starting to realize a lot of the benefits. So there was definitely pushback, but once we started education and working and showing how we can customize it to their benefit, how information is private, how role-based access is there, and information isn't shared that is not agreed to be shared, a lot of those barriers have started to break down. Not saying there isn't barriers, but it is, lots more agencies are open to the conversation now. Our main barrier now is capacity. I have a 4-person team, and so we have several agencies that have reached out recently to join, and it's a fair big process to onboard, and so that's something that we've been, there's actually more of a barrier now than people not wanting to join.
Yeah. Thank you.
Yeah, no worries, thank you.
Just a follow-up question to what you were talking about before. My name's Erin. I'm from Hamilton. I'm director of a women's shelter in Hamilton. And we have 4 gender-based violence shelters in Hamilton and 4 shelters for women who are experiencing homelessness. And the homelessness shelters are using HIFIS and the gender-based violence shelters are not. Can you talk a little bit about what is the advantage of those gender-based violence shelters that are using HIFIS, what's motivating them to use it, and why would they choose to use that?
Yes, so the primary one, it's in Regina. The benefit was that having all of their systems on the same server or the same access one of them was for reporting to make things easier standards across the system. They also used HIFIS 3.8, so there was an understanding of how the system operated a little bit from previous. But working with them and showing them this is how we can hide information. You can hide service provider data as well in HIFIS. They chose not to. We did offer, I did offer the option of we can operate a separate cluster to separate it out. They chose to have everything within one and instead work with Declined Anonymous to protect privacy. And then we built them some anonymous, even anonymous files, almost like dummy files that they could book a bed in without having any identified information at all. So for them, it was truly creating service standards that their staff could all work and log into the different ones that they only needed to access. So if there was a staff member that did not work in the DV shelter, they wouldn't have access to it or see any of the information. So we created different providers for each of those programs to ensure that no information was shared.
So that's how information is not shared, but why would a gender-based violence shelter choose to use HIFIS as opposed to a different kind of client case management software?
They didn't have another. So they previously used HIFIS for that program as well. So they wanted to continue to use it. And now the initial conversations were before my time in the program about how they would use it. I primarily worked with getting them on board. I know there was a lot of concerns about at the initial for this shelter regarding privacy sharing. Part of the shelter is Reaching Home funded, one of their programs, and so they wanted to instead of onboarding only like one program or 2 programs, the management of the shelter was like, if we're going to do it, we're going to do all of them, and so that we can all have the same process. We can have reports that have the same standards across the board.
Any other question before we wrap up?
Hello, thanks for the presentations. Just a question for Brenna, and anyone else feel free to jump in. Did you have to work through, with any First Nations groups, the OCAP principles in any way? And if you did, do you have any recommendations or learnings from that?
So yes, it's also something we are still working on. It is ever evolving, and it's often a conversation that I have with Indigenous groups about how we can better work together and how HIFIS can work for them. One thing, I mentioned a bit of that governance structure, and that's part of that better aligning with the Indigenous data sovereignty. In Saskatchewan, our 2022 PIC count data showed that we have an 80% to 90% representative of Indigenous individuals in our homelessness data. And so ensuring that our coordinated access governance and those governance groups that are making those decisions are representative of the people that we are serving. So making sure that coordinated access, the governance is 80% Indigenous to be able to have those conversations. But also it's not an easy answer. It's something that I'm continuously working on. It's implementing different strategies regarding in-group activities, building out a full cultural activities between sewing, crafts, knowledge keeping, elders, everything within the system to allow them to best show how individuals interact on a cultural level, and building that into the capacity of the system, as well as building in goods and services, the ability to show Indigenous practices, giving of Indigenous goods, cigarettes, tobacco, everything like that to better align with how they're operating. What I've found is that it comes down to working with agencies at how they operate so that HIFIS can work for them, not necessarily they work for HIFIS. It's a good program. It's not the answer to everything, but it is a very good program for what it does. And so the best job that I can do is make things easier for agencies. And so that's how I go into those conversations of how do I make your lives easier through data. And if we have to change our policies to ensure that OCAP and Indigenous ways of knowing are being followed, I'm more than happy to do that. And it's actually something that will very likely happen.
Thank you.
Sure, one last one. Go.
Sorry, one last question. Brenna, you talked about all of the agencies owning their own data.
Yes.
I'm not a HIFIS nerd like Allie, but I am a HIFIS learning person. Based on what I have experienced from our HIFIS owners, they tell me that we own our community data through crystal reports. Now, to me, that's not owning data, because all that does is spit out a report where I would have to scrape any data off of. So how do you do it in Saskatchewan?
So agencies' data belongs to them in that I'm not going to report on what they do to someone else. No other agency can pull data from their organization. They do not have access to pull information or data or stats on another organization. There's a caveat that there is that export to the federal level for the licensing to use the system, but that's aggregated. But agency-specific data is their stats. What they do is it belongs to them. No, another agency isn't going to pull their stats. They don't have access to it from our end.
So when you're talking about it, it's basically their stats. They don't necessarily have access to the raw data to run other information that they might want to run that might not be supported by HIFIS because it's not a statistical tool.
Like in terms of, if they request a report, and I tell them constantly and work with agencies, if it's in HIFIS, we can work to pull it. If it's not in the system, Allie would be very good at this point. I don't mention much with reports. I'm sorry.
That's okay.
Allie's much better at this aspect than I am.
I'm just going to chime in uninvited here.
Not uninvited.
So I think what Brenna is trying to say is that they've made a decision that organizations aren't allowed, they don't have permission in terms of their agreements about saying this other shelter over there had an occupancy rate or served this many people or something like that. They only have permission to utilize their own service providers' data.
Yeah.
And then what you're kind of speaking is who has access to the raw data in the database. So I think the answer is actually kind of, you're saying the same thing, but in different languages. So the database is going to be hosted by whoever has the HIFIS license, which in your case is SHIP.
Yeah.
And in your case is BC Housing. And so they're the people that have direct... Oh, it was just some mystery, I don't know, some other agency. So they're the people that have the raw access to the database itself because they're hosting it. They have the database on their server and so on and so forth. Now, to extract information from the database, you require a report. And so you're all using the same language of there would be a report that pulls data out.
Yeah.
And I think there may be a conversation about who has the permission to develop reports, because in developing the reports, you need access to the database. So that might be where some of the conversation is going.
Yeah.
So who has the
Yeah.
permission to develop a report? And then once the report exists, what you're allowed to do with that. So there's kind of two different things
Yeah.
going on here, I think.
Yes, I have someone on my team who will develop reports, and we develop reports by request. So if an agency is like, I want to see how many individuals we've served in the last month, we can develop that for them, and they can pull and work with that, however, for themselves, how they would like.
Thank you.
We develop the reports on staff. No, we develop it. We have someone who understands the database of this and the tables of the system.
Okay, thank you, Brenna. I think our time is almost like well spent, and I want to appreciate our presenters. Do you want to appreciate? Also, I want to thank everyone for coming. Check around you. Make sure you don't leave your items behind, and have a wonderful evening.